Hello, everyone. I welcome all of you on behalf of IASNM Nuclear Medicine and Webinar series. This session will be a 45-minute presentation, followed by 15-minute question and answer session. And you may submit your question via the chat box throughout the session. We will address the questions as they are received. And it is now my absolute pleasure to introduce Dr. Bital Savir, Associate Professor of Radiology and Chief of Nuclear Medicine Division in the Department of Medical Imaging at University of Arizona. Dr. Savir completed a research fellowship in nuclear medicine residency at Emory University Hospital in Atlanta, Georgia. And then she was practicing at University of Loyola, Chicago, before she joined University of Arizona as the section chief. In addition to clinical expertise in diagnosing and managing prostate, thyroid, neuroendocrine, and breast cancer, Dr. Savir specializes in diagnosing patients with cardiac amyloidosis and sarcoidosis. She is board certified in nuclear medicine and nuclear cardiology. Dr. Savir.
Thank you so much. First of all, I am delighted to be here. Thank you so much for this introduction. You know, I always say that in the United States, the Society of Nuclear Medicine is a very small one that everybody knows everybody, and it is a pleasure to work with these talented people here, and everybody's one success is essentially everybody's success, because at the end of the day, we're sort of helping each other. So it is my honor to be here, and thank you very much. Just a little bit of a disclosure. I am still affiliated with Loyola University Chicago. So here you're gonna see the logo. I am working at the University of Arizona that merged together to Banner Health. So they created the Banner University Medical Center. And that's what basically you see here. I did join the department a year ago. I have a great pleasure to really open a Theranostic center. We start running it. And I do know I give a lecture today to a lot of people that probably have more experience than us of how to use things. So bear with me, because I want to present to you our issues here in the United States and what we're doing to solve it. But I obviously gonna speak from the imaging side rather than the oncology. Many times we do bring some oncologists and radiation oncologists to know how we can solve those issues. So I'll share as much as I can. So the objectives of this session is to really understand the limitation of conventional images. And believe it or not, in the United States, we're still seeing it again and again being used for staging and restaging. And then the use of PET-CT in general for primary and recurrent prostate cancer. And then obviously the application of theranostics. The main idea that I hear from the oncologists and the urologists is that it creates a lot of disruption and uncertainty, because we thought we knew what we knew and maybe we didn't. So if you go back to 2016, the New England Journal of Medicine came in I think it was like a 30,000 patient study that says that no matter what you do for primary prostate cancer, the outcome will be the same. Mortality is not going to be as high in a 10 years outcome, and it doesn't matter what treatment you choose. Yet, you know, prostate cancer is a second mortality in the United States. So when you look at that, you're asking yourself, did we do it correctly? Is this study really a representative of the truth? So let me show you the doubt that I have. So what do we want to know? When we have someone that has a newly diagnosed prostate cancer, we're really using the histology, and even there, we can go and argue that we can have a better way of diagnosis of how to perform the histology. We want to know the staging. And then with recurrent disease, we're usually using as a tumor marker the PSA, where how much it raised, if the patient had prostatectomy or not. There are different criteria, which I'm not going to go in today. And then when we do the restaging, we only take histology if we end up seeing something on those images. But at the end of the day, we want to know if there is disease solely in the prostate or a recurrent disease in the prostate. Is there extraprostatic disease, oligometastatic disease, or polymetastatic disease, if the patient state is hormone sensitive or at this point already resistant? And that will allow us to choose some kind of management. So what did we used to have before 2016? We had on the newly diagnostic, we usually used a positive biopsy, and on the recurrent disease, everybody would get CT chest down on a pelvis, plus minus bone scan, depends, usually weed. And then we do know that in both cases, the CT very, very often will fail to localize those small, normal appearing metastatic disease. And also at a very, very low PSA level on the recurrence side, the CT will be very limited. So for the primary disease, they would basically treat based on the histology and the risk group of the patient. When it comes to the recurrent disease, many times in the United States, back in the years, the recurrent disease will be based on the theoretical spread of the disease because, again, the images were absolutely negative. So we needed to understand the pattern of the disease and look at the available literature. And many times patients would just get blindly radiation therapy to the pelvis. In both cases, PSA would be monitored either for recurrence after the newly diagnosed and then continue to be monitored through life. We know that this is not the game anymore because we had this like vicious cycles that go by CT and then MRI for the prostate. And if we saw something, we do radiation therapy. If we see, we're gonna need to mute everybody. And then we have, chemotherapy when the staging, when the CT or the MRI become positive. And at this point, we know it's maybe just the tip of the iceberg. Despite all of that, prostate cancer is still the second leading cause cancer in American men behind only lung cancer. So in overall, we think we knew, but in reality, we didn't really know. And that takes me into the new modalities. And bear with me, because in 2016, compared to a lot of places, we actually have had fluciclovine. Now, I'm originally from Israel. They never used it there. Saima told me that they never used it here. But what we had in 2016, it's fluciclovine, and I'm sure that most of you heard about it. It is an amino acid-based tracer. I had the honor to be part of the early group that investigated at Emory. And it basically works on metabolism and proliferation through the mTOR pattern, which is a known oncometabolism and very, very active in prostate cancer. So on the other hand, very recently, in the end of 2021, it was becoming globally available that we had the PSMA that is working. It's a different type of tracer. And it's a key and a lock, basically based on prostate-specific membrane antigen. And the two ones that are available here in the United States is the TPYL and the PSMA11, Pylirify, and Locomets. So when you speak with the oncologist, we did create some disruption and uncertainty. And why is that? Let me take you for the clinical perspective. We as imager, we're so thrilled. Now we can see everything and we know where the disease. And at the end of the day, what do you do with that? And when we took a subgroup of fluciclovine, and not just, again, fluciclovine, PSMA, it's just an example of the concept of biological and biological pattern using molecular imaging. And what does that mean? It means that if we had a person that had both CT and fluciclovine, that was back in the day called FACDC, we could see that only 17% of those CTs were positive. And I'm talking about diagnostic CTs, not the PET CT. And the PET portion was positive in 78% of the time, which is creating a little bit of a shock. So let me emphasize how did it look back in 2016. This is a person that had a tiny lymph node, and you can see that there is no way anybody on that beautiful fatty hyaline contained lymph node would ever call that positive on conventional images. And that was the first time that we actually realized that someone with recurrent disease, that the PSA was essentially low, he had no local recurrent. He actually had uptake in a lymph node outside of his pelvis, which means that if this patient will go to external beam radiation therapy or whole pelvis radiation therapy, at this point, he would absolutely fail without even knowing why. And as one of the first evidence that we also understand that the word micrometastasis or metastatic lesion in a normal appearing structures is a real deal. So this is one of my first clinical cases in 2016 on a patient who was supposed to go to salvage radiation therapy. He had multiple negative biopsies to his prostate. And then when he came to me actually on the same day, his PSA was 40 when he was doing his pre-authorization. When he was sent to me, his PSA was 26. So rapid kinetic. And interestingly enough, you can see that he had one in the pelvis that would be taken care of, but the rest of the lesion in the retroperitoneum and in the bone, despite a negative CT and a bone scan on the same 3 months, basically he would fail. And again, this person needed to start hormonal therapy. So this would not be an appropriate therapy. So fluciclovine, for those who don't know, and it's important to understand that I rarely now speak about the mechanism, but it's important for those who don't use it to understand why it's an okay tracer, but it's not the best we can have. So fluciclovine will go into the cell through the amino acid transporters, but for every one amino acid to go in, one has to come out. Despite all of it, we still saw that over at the course of 60 minutes, the uptake within the malignant lesion, whether it's prostate or lymph node, will be higher than that of benign lesions. And therefore, now you understand that for those that image at the 4 minutes, this is why we image at the 4 minutes, because we don't want to wait for that to wash out. But there are some limitations. And one of the limitations, this is one of the early cases of my colleagues from the VA. And he called me and he said, Bital, I don't understand how you deal with this study. Like, how would you call it? This is a negative study. There is no way this person is negative. So now I opened the study, it was fully anonymized. I opened the study and I looked at this and I said, yeah, that is positive. He said, how would you call that positive? I said, well, change the view, increase the intensity. And now you can see that the uptake is equal to the marrow. So it is positive. And it was true positive by biopsy. But the concept is that you can create and that you can understand how it's creating among the imagers that were not basically grew with their career from infancy with this tracer. It creates a lot of problems. How do you read it? And then you realize over the years that people don't really know how to read it correctly. There is overcall and undercall, and it became sort of a catastrophe, to my opinion. But anyway, it was very hard to read, and I still love fluciclovine very much, still using it, but it's very hard to read unless you do the appropriate training. And there's a lot available, but not everybody is spending the time. So over the years, when you become an expert, you can actually see that the tiny lymph nodes that are 5 millimeters, 6 millimeters, 7 millimeter, if the uptake is approaching the marrow and is significantly above blood pool, you can actually start calling them. And when I looked at my own facility, when I was at Loyola, our sensitivities were in the 80s, 90s with the specificity of around 70%. So you can do great if you become an expert on that tracer. And then the new kid on the block came, and it's not that new anymore. And it's definitely not new in India. You know, United States is somewhat behind Europe and also Israel when it comes to new tracers. So we understand that a new kid on the block for us, it's an old member of other neighborhoods, but it was a new kid on the block for us, and it is the PSMA tracers. And now going from an image that you really need to have a good expertise of reading, now you have a tracer that everything looks like a light bulb. And you can see here on the images, you can see how uptake in the bone lesions, it's so impressive that it's very easy to read. And seriously, that with good training, every level of radiologist, nuclear medicine physician can read those. So that being said, it is that sensitive. And instead of going backward, I'm going to give you the last page of the book regarding that. In February 2022, you know, United States work by the NCCN guidelines. We don't do things differently. And it actually showed that because of increased sensitivity, PSMA, PET-CT, or PET-MR should be now the frontline images because it's more sensitive in the detection of small lymph nodes and it's better than CT or MRI. And now officially can be used for both initial and recurrent disease, where fluciclovine was only for recurrent disease. So now we have a wider population. And that's also interesting because of administration, because now imagine yourself, we supposedly supposed to replace CT chest, abdomen, and pelvis with PET-CT. Demand going to increase significantly. So now that I gave you the last page, let me explain how the NCCN guidelines really included that. So, and what are the studies behind it? So for primary prostate cancer, there are two questions we want to answer. One, how can we get the most accurate histology from the prostate gland? And the second thing, the cat is out of the bag. Do we find any lymph nodes involved? So I won't go into all the studies, but those are the three main studies that are out there that if you basically look at all of them, the conclusion of the study was when you're combining the PSMA PET with an MR for the localization of more histology aggressive lesions within the prostate gland, you will have more accurate finding than using one or the other methods alone. And you can see that all the studies looking at significantly higher area under the curve and different types of remodeling and statistics, they all came into the same conclusion that you should incorporate PSA into prostate biopsy planning. So for the questions of the lymph nodes, there are multiple studies that were done here between the United States, Canada, some of them in Europe, and a big contributor for the PSMA world is in Australia by Hoffman. And you can see that the ProPSMA study was a study that randomized two arms. One is standard of care, and bone scan today considered also standard of care as first-line images. And then 50% were allocated to receive also PSMA, and they looked at accuracy of first-line images. The other study was done here in the United States and Canada. There's the Osprey study. There are two arms. The first arm was for primary. The second arm was recurrent disease, and we'll speak about it a little bit later. But they again got everybody on that arm. It's a single arm for that purpose of primary disease, and everyone that went into the Pylirify, you see the first one was gallium. This is F18 Pylirify. In fact, went into lymph node dissection as standard of truth, and everything you see here had been compared to standard of truth. And this primary standard of truth of histology. And this primary endpoint was sensitivity and specificity. So looking at a ProPSMA in Australia, we're looking at a sensitivity of 85 versus only 38. And again, this is showing, if you compare the one that I showed you with the CT and the fluciclovine, the numbers here are a little bit higher, but very, very low for the conventional imaging. Specificity is obviously pretty much the same, just because when you already see something on CT, obviously it's going to be positive. It takes time to show those morphological changes. And then on accuracy, it's much more accurate. So also they looked at other factors. For example, how many studies had less equivocal findings, and you can definitely see that the winner was PSMA images, and it has better effect on management, meaning that the physicians felt much more comfortable with the PSMA 11. And interestingly enough, you know, there is always this hysteria around the amount of radiation. The patient that had a faster diagnosis, in fact, had less images to reach to the diagnosis and therefore had less overall radiation dose. When we went to the Osprey study with PYL, it's an interesting finding because they really did not set up the role of like how low would you go in terms of the size of the lymph node. And remember I said the word of micrometastasis, it's becoming a big deal here. So the Osprey had 62 men that had at least one pathological proven pelvic lymph node. When they did the lymph node dissection, they actually did not reach their endpoint of sensitivity. And you can see that between the CT and the PSMA images, there were no differences, which was very suspicious. The negative predictive value were not that high. And interestingly enough, the specificity was higher. So let's look at the other way around. What they did, they said, okay, if we will put the a size limit of above 5 millimeter lymph node, And then we will see the differences. Now the sensitivity became much, much higher of 60% and compared to 40%. And that you can see here. You can see here on that graph is where the lymph nodes were above 5 millimeter. And remember that because Emory, Dr. Schuster, did something similar with fluciclovine. And I think one of the biggest home message is like, how low do you go when it comes to lymph nodes to understand the ability of the machine to detect the lesion. So when you look at one of their studies, despite this low sensitivity, when you look at the images, this is how it looks like. On the left-hand side, you have a bone scan that was equivocal on the left iliac crest where the error is, but this is in fact where you see positive. So even if an exam is positive, many times on the conventional images, it showed you the tip of the iceberg. So one of the interesting things, and that's what I said, so Dr. Schuster at Emory did a very interesting study to look at patients with newly diagnosed high-risk prostate cancer that were supposed to go into prostatectomy and lymph node dissection. And out of 57%, his sensitivity was much higher than conventional images. But when you look at that per template, the sensitivity was 46%, which you would assume they will be higher. And we do know that you now, based on that, and again, it wasn't much of the conclusion, but it's again and again, we do understand that for primary disease, it's very, very hard to replace imaging with lymph node dissection or any biopsy of lymph nodes because we're not sensitive enough. And where it's coming to, I think to make the biggest point of it is that when the diameter of the metastatic foci, and that's not even the lymph node, that's the metastatic foci, you can see that when it's below 3 millimeter, the ability of the PET CT, and those are digital PET CTs, the best out there, it's just 20%, where it goes into 9 millimeter, and now you're looking at 83%. When you see all of that, it takes you to understand, it takes a minute, but you do understand that probably the Osprey study that failed to get into the first primary probably had a lot of patients with very, very small areas of metastatic disease, because no matter how good we are, we can really not replace the biopsy and the resection with that kind of histology method. So that again takes us with a grain of salt that when we look at recurrent disease, maybe just the tip of the iceberg still. So again, that creates another disruption and uncertainty, because when we see much more now, we have more upfront systemic therapies, like patients are going on ADT, and we all know that ADT, it's a very, very hard treatment for a guy. And also we are starting to look, maybe we should apply more selective therapies for patients with oligometastatic disease. And then we ask ourselves, are they really oligometastatic disease, right? Based on what I just showed. And then what is the best therapeutic approach? And we are yet to answer that question. So going into the biochemical recurrence for staging, we have multiple studies, and just for the detection rate of what we have here in the United States, you can see that the overall detection rate for PSMA 11 was 75. Even when PSA below 0.5, it's still very significant, 38. Usually it's 0 for conventional images. Fluciclovine on real life was above 1, was around almost 60%. Above less than 0.2 does not even considered to be biochemical recurrence. We really had a 43% positivity rate, and also 55 when it was 0.5 to 1. Osprey arm B was the recurrent disease. You can see 50% sensitivity for less than 0.2%, a little bit higher than fluciclovine. And then there is another study, is the Condor study, that also showed recurrent disease detection rate of 36 when PSA is less than 0.5. So when you look at the diagnostic performance, this is a study was done in UCLA. It's a single arm clinical study with complete histological confirmation. And you can see that the sensitivity now is 92. And again, why is that? Remember that we only biopsy what we see. We don't go and remove everything compared to lymph node dissection on the primary. When we remove everything, we're looking at those 3 millimeter foci that on the recurrent disease, we will never touch. So it's what we see, what we go after, and then the sensitivity becomes very high. And this is where, you know, the differences in numbers. So again, when you look at the Osprey study, the RMB sensitivity is 96%. It's almost equal to perfect, and positive predictive value is 82. Those numbers are just fantastic. The detected distance metastatic disease was almost 60% higher than the one, 60% of those with negative conventional images, which is very important as well. When you look at the Condor study, you're looking at positive predictive value between the 3 readers. This is individual readers of 67 to 73 with, for extraprostatic disease, extrapelvic disease, sorry, it's 67 to 69. Again, very high numbers they have really small lymph nodes there as well. When you're looking at the diagnostic performance of fluciclovine, it's a different method. We looked at 57 sensitivity and 94, but this is in fact was not even whole body images. It was just upper abdomen and pelvis. So you can understand why that happens. And then the extraprostatic positive predictive value was actually 92% when they included all studies from United States and Europe. And again, just to remind you, the biggest discrepancies, the disturbance is that we still looked when we started with 17% performance on CT images. So how does it look? Basically, this is an example of a patient that had prostate cancer, one of the clinical pylarify images. And you can see here, there is something that looks like a lymph node, but because of the 4 millimeter, this is 2 millimeter, this is 4 millimeter. And you can see that, actually, no, I'm taking it back. This is also 4 millimeter. It's not a whole body. And you can see that you can barely see the lymph node here. It's less than 5 millimeter, yet look how intense it is. All of those lymph nodes were looking exactly the same. So you could barely see them on CT images. So again, what's the best therapeutic approach? Again, the same question. Are we selecting therapies for oligometastatic disease? Will that result in a better outcome? And this is where the key stands. We need to show outcome of different methods of treatments. So let me go into the ADT world. What about response to ADT? As I said before, probably the amount of patients going to go an upfront hormonal therapy because of those images is already higher. And then at some point in their therapy, they will actually progress after chemotherapy. After hormonal therapy, they will progress into metastatic castrating resistant state. And what do we do then? And how we can really determine that in the early stages to help them not to progress too fast. So one of the things about the PSMA ligand tracer disadvantage, there are two studies looking at that. And we do know that the androgen receptors control the expression of PSMA. On the short term, it creates some kind of a rebound. On the long term, it decreases the sensitivity. So if you try to mimic how it looks like, sorry about my non-Picasso here, when you block the androgen receptors on the PSMA on the short term, you're going to have expression of more PSMA in theory. And then what happened is that the study will look like it's getting worse. On the long run, because of the constant block of those receptors, the rebound will stop. We don't really know when is that happening. And then even if you have recurrent disease, essentially, theoretically, you will decrease the sensitivity of it. Why I say theoretically, I don't think there is enough data to understand what to do with that yet, and that needs to be investigated. So I always say if one doesn't work, maybe the other will come to our rescue. And here in the United States, we do have the fluciclovine, and I always say try not to bury too fast. There is still use, it's apples and oranges. And we actually saw at Loyola that between this population that received hormonal therapy and had persistent increased PSA level compared to those with increased PSA level, but not on hormonal therapy, we do see that the detection rate is actually the same. And as always, as we show that PSA is a good predictor for positive scans, we can see that it has almost the same concept of increasing PSA level with increasing increased detection rate with increasing PSA level. So how does it look in reality? This is a person that initially diagnosed with metastatic prostate cancer, Gleason 9, and you can see a lymph node here on the left and another lymph node sitting here, bone lesion and retroperitoneal lymphadenopathy, all consistent with prostate cancer. He started ADT, nadir, PSA lowest one was 0.26, and then continued to increase while on ADT. So the scan day was already 0.34, very low, but still increasing. And you can definitely see that there is a very nice response here. This is exactly the same slice, and you can see that those areas were melted away, beautiful. But you do see that unfortunately the left external iliac lymph node and the left pubic lesion were still there, were still avid. And this is where we actually looking at heterogeneity. Now I'm jumping to the breast world for a second. For fluoroestradiol that was just recently approved, we know that disease heterogeneity is a known thing. And again, we just knew the tip of the iceberg. And now we see with prostate that there is also stage of heterogeneity before it become full-born metastatic castratic resistant disease. So the main question that I will be being asked, like, so, okay, you have your practice, you have the both, you have the PSMA, the fluciclovine, which one you choose? Very hard question to answer, but actually myself and David Schuster, we looked at both studies, and basically we took the patients that had fluciclovine and PSMA head-to-head in one of the European studies. And you can see that PSA above 2, you see absolutely no differences in detection rate. It's where you take the PSA of less than 2 in one of the study, and the one that was done here in the United States is where you really see delineation, where fluciclovine is significantly superior to the detection of local recurrence because the PSMA has a lot of urine secretion and it's usually masking the area. However, PSA was better on the detection of extraprostatic disease. So there is the Empire 2 that's happening right now at Emory. This is interim analysis that you have randomized trial for fluciclovine, which considers standard of care today. And then gallium PSMA 11 that before that study was not approved yet, just to see if it will change outcome for patients that are going to radiation therapy. The interim analysis looking at one group compared to the other, even though it wasn't the first endpoint of that study, shows that there is, again, superior detection for local recurrence with fluciclovine, despite the use of diuretics. And then there is no significant differences that was found for extraprostatic detection. Again, this is a different goal, but again, take it with a grain of salt for those that are practicing in the United States. Each one has its own role. And again, we have another disruption, and uncertainty, because when I've been asked which one do I need to choose, and what if one of them will be negative? Because if PSMA in the United States is negative, immediately we're thinking that we missed the local recurrence. But when we have negative fluciclovine, we immediately thinking that we're not saying small lymph nodes that would be positive on PSMA. And yes, in the United States, you can get them both most of the time. So what about change in management? Diagnosis leads to accurate treatment, obviously. So on the left side, let me just postpone trying to restart my computer. So the change of management on the Condor study on the left, you can see 64% change of management, and even when the study was positive or negative. So both of the studies helping into the decision making. And then on the other side, where is the Locate study, we have 60% change in management, despite the fact that some of them were negative scans. So again, both negative and positive PET-CT, whether it's fluciclovine or PSMA, help in the management of patients with recurrent disease. So now that we see more, did we make any difference? And that looks at outcome. So again, there is the study that the Oriole, some of them had, which was for selective radiation therapy. There was a subgroup that had PYL. And on this group, they said that when you had this biological image that has such a high sensitivity, you can actually consolidate all the detectable disease and you can actually administer therapy to it, you can get better outcome. And they support the molecular imaging for metastatic therapy for patients with oligometastatic disease. A study that looked, this is the Empire one, which is conventional arm versus the additional of fluciclovine. At that time was not standard of care. When you basically use molecular imaging to direct therapy, in this case is radiation therapy, you can see that the failure-free survival was significantly higher for the additional of fluciclovine with 35% change in therapy approach. So again, what do I choose on the PSMA? It's a receptor-based fluciclovine, it's amino acid transporters. The only FDA approved actually for primary staging you can use, and you can use them both for recurrent disease. And then for biochemical recurrence, we do know that it might be better for extraprostatic disease. At this point, again, we need more data when PSA is less than 2, and high performance of the localization of both local and extraprostatic. But again, we need more data. As I told you before, some of the studies did not include whole body images. And then it is limited for the evaluation of local recurrence. Majority of my cases, I have to say the disclaimer that I cannot see the area of anastomosis or even the prostate after radiation. You just have so much urine. And then maybe used with patient in hormonal therapy, that's for fluciclovine. And then PSMA is significantly easier to read, and the fluciclovine, you really need to have a good teaching. So the most important thing, PSMA is the one that we can use today for Theranostic, and then can that be used to predict PSMA ligand therapy failure? For those who don't know, we cannot use FDG images in the United States for prostate cancer, and it will be very nice to have some kind of image to see if we can see discrepancies between the two. And with that, I'm going into the concept of Theranostic. With the use of nanoscience, we have the ability today to really mark one cell and then apply therapy. And this is where the Theranostic word was born. Some places use Diagnostic for the therapy and the diagnostic. The concept is that we have a cancer cell, we have some kind of a target on it. We're creating and synthesizing a ligand or a peptide to attach to it. We're creating with the nanoscience linker, and in many cases is the DOTA, and then we are using radioactive agent. In the prostate cancer cell, we have targeted, which is PSMA membrane binding. We're creating the binding motif that has a linker, and then we can either put gallium-68 or PSMA-11 on the therapeutic. We have lutetium-177, but you can also put Y90 there. And those are just the tip of the iceberg of all the motif and the ligands that have been created over the years. The concept is that you use a diagnostic tool to look at the disease, and then you repetitively treating. Now it's 6 times, and then you continue to survive, to do a surveillance. And this is one of the examples where actually the therapy worked. The 2 major studies that we have that we all looking to their results and learn from it is that therapy was done in Australia. Therapy was a randomized trial between PSMA 617 as an arm for those that needed second-line therapy after docetaxel and now are eligible for cabazitaxel. And the second group was only cabazitaxel. So that's a very, very controlled study. The VISION trial was a person that failed on standard of care, either abiraterone or enzalutamide, which are hormonal therapy blockers, and then 1 or 2 taxane regimen, not necessarily a second line at this point. So the population I would call it a little bit sicker population compared to the therapy study. So on the vision study, you basically need to have a proof of metastatic disease on conventional images with positive on PSMA, without discrepancies between the two, meaning that you have CT lesion, you know it's cancer, and doesn't take the PSMA 11 PET. On the therapy, you wanted to have positive metastatic lesions on PSMA 11, at least one lesion with SUV max above 20, which is interesting, and you will soon know why. And then everything else had to be SUV max above 10. They also had FDG for the screening and made sure there are no positive FDG sugar base and negative PSMA. And if that's the case, those patients would be excluded from the study. So they had true PSMA positive disease. So this is a very busy slide, but I want you to see, because a lot of people now start treating, and one of the questions would be, can I continue my therapy? So yes, certain therapies. So this was, the vision was the best standard of care plus PSMA therapy, not just PSMA. So any dose, at any dose of the hormonal therapy or corticosteroids with radiation therapy or bisphosphonates, but they could not have full-borne chemotherapy. That was not allowed. That was not involved in that study. So if they were supposed to continue to take cabazitaxel, that's where they need to stop. And then they received 200 millicurie every 6 weeks, maximum of 4 cycles, and they could get into 6 cycles as needed per response. If they did great, they needed to continue to have their testosterone low, so they were all probably on Lupron. And then they would check with CT and blood work for response. So really, I'm not going to go to all of it, but just to show you that out of 831, the one that were assigned to receive PSMA, just to show you that 484 patients, the majority actually discontinued standard care because they didn't help them. So if now you see patients claiming that they just don't give it anymore, that is part of the reasons. So basically 49 out of those 500 end up continuing standard care regimen, where on the other side of the standard of care, at the end of the day, only 5 continued on it. So again, this is where you see a lot of patients not necessarily continuing with standard of care. So how does it look, the vision trial? You can see there is a much better progression-free survival of almost 9 months compared to 3.5 months. Overall survival was higher in 3 months, between 15 to 11, 4 months, sorry, between 15 to 11, with 38% less risk of death. And then the time to first symptomatic skeletal event was actually almost doubled, with 50% less risk. So the therapy trial profile, it's interesting because here they had a very specific, as I said, 50% went to cabazitaxel and 50% allocated. Vision was like 1:2 ratio. I'm sorry, I had a phone call, so I had to disconnect that. I hope you all hear me. And then the second one would be that after they're doing those allocation, they would look the efficiency of everything. And then PSMA positive disease, again, as I said before, they have to have, and this is one of the keys of the study and the big differences in our population. So the therapy protocol had cabazitaxel on the left side, and then again, compared to us that we started in the United States and Europe, and the Australian study started with 230, which is 8.5, that is 0.5 gigabecquerel per cycle. We continued with the 200 millicuries. So again, they did blood work and 12 weeks until radiological progression. If they saw it, they stopped to do some conventional images. So the therapy results showed 50% reduction from baseline in 66% of the patient compared to only 37%. And they do have delayed progression as compared to cabazitaxel. So also they showed a better objective response, and then radiological progression was significantly better for the PSMA group, and the PSA progression-free survival was actually much better again for the PSMA group. Now, interestingly enough, when they published their first study, they did not have outcome for overall survival. And just recently, a couple of months ago, they came up in ASCO and said, surprise, surprise, overall survival is exactly the same between the two groups compared to our VISION trial that showed benefit. However, with all of that, we have to remember the differences, because this is a second line versus second line. Cabozantinib is an excellent chemotherapy. It helps. So to prove that it does actually as good as the other one is actually a great success. And if you look at the overall survival, it was higher than what the VISION trial showed. So in other words, you say, yes, you can actually use PSMA instead of going to cabozantinib. You can actually go and choose to go to PSMA therapy because of better, lower adverse events, higher response rate, and also improved patient report outcome. This is not chemotherapy. And again, very similar overall survival, which some people thought it's a bad deal. It's not a bad deal, it's a great deal. And another sub-analysis, and that gets us to the SUV max of the importance. Again, gallium and F18 are a little bit different, and every scan has different level of SUV max. So take that with some kind of grain of salt, but get the idea that SUV max that was above 10 in that study actually showed much better outcome of progression-free survival for those lesions that had had SUV max of less than 10. But again, it has to be specified for reconstruction, because we know that the digital PET by default will be higher SUV maxes. So now officially, it is within the NCCN guidelines. If I showed you version 2, I don't remember ever seeing NCCN guidelines changing so fast for the world of nuclear medicine. So we did something good here in the United States. And it is actually approved now for patients with predominantly, they didn't say predominantly positive, they said predominantly no dominant PSA negative metastatic disease, to allow a broader population to enjoy that treatment. And then already treated and failed on androgen receptor direct therapy, enzalutamide, as I said before, albuterol, and then any taxane-based chemotherapy. And I think I have a typo here, I apologize. And then both, and that's the latest improvement, that both pylorify and gallium PSMA-11 can be used. And the reason why, it's because the VISION trial was only with PSMA-11, and it was hard to get at the beginning. So we are very happy to see that pylorify is actually part of that package. So just really 2 minutes about eligibility. You really want to, this is a patient that came to us to see if he's eligible, and he had disease in the bones and the lungs, and everything was positive, and there were no discrepancies between this and the images. And today, by the way, it called here Pluvicto. I don't know who gives those names, but it calls Pluvicto. And this is an interesting, because this is a patient just before Pluvicto was approved here. This is a patient that initially presented with a very positive bone scan and got chemotherapy and enzalutamide, and this is how it looked like. But then his PSA continued to rise, and this is a CT images. It looks like everywhere is involved, but we didn't know if it's active or not, because those changes were constant. And I couldn't give him the radium, the Sofigo. It didn't make any sense to me. I asked for PSMA PET CT, and you can see that again, now what we thought we saw was the tip of the iceberg. It was primarily bone disease, and he just received this treatment. So how does it look? You do 6 treatments every 6 weeks. And every 6 weeks, you also check for labs, which including CCMP. You want to make sure they don't go into toxicity, or blood toxicity, or renal or liver failure. And we are using the same as Lutathera minus the pump. We're not using a pump. I find that much easier to do. And this is how we actually administer that. And in reality, this is how the nice box is looking like. And this is our setting. This weekend, I'm building the nice box that my colleague at Loyola had. So wish me luck. I'm going to need to cut a lot of acrylic products and to build a nice box to cover that. Just for making it more elegant and less mobile. And this is the ion chamber that we're measuring to make sure everything is there. And compared to that they ask you to wait for 5 minutes when the radiation level inside is not really changing, we actually inject through here, we inject some air into that vial until the vial is empty, and then we clamp, we'll never get the air out of it. That's done by physician. So we actually empty the vial to the patient without increasing risk. So again, the last thing about it is the disruption and uncertainty. What is the better selection of PSMA? Can we treat sooner? How many patients going to really complete the treatment? I have around, I would say 20% failure already. Benefit as first-line therapy compared for polymetastatic, for oligometastatic, and what about the hormone positive population, sensitive population? So I think the most important study that we're all waiting to come out is the PSMA addition, which is a phase 3 trial to look at PSMA plus standard of care versus standard of care only with hormone-sensitive prostate cancer patients. And if you look at clinicaltrials.gov, you can see we have patients that are looking at, this is again Australia, looking at different combination of this versus other treatments. And this is androgen receptor direct therapy versus lutetium PSMA, and then cabazitaxel together, and that's again in Australia, together with PSMA to look at toxicity, because we know that we don't know that answer yet. And then what about oligometastatic hormone sensitive, really early metastatic disease, looking at that in the Netherlands. And the last thing that I thought super interesting, and I know you guys have experience, is the alpha. Are you doing it immediately? What about the byproducts? And then do you preserve that for patients that failed on lutetium? There is a lot of approach like that in the neuroendocrine tumor world. And in other words, when people say this disruption, to me, it is the same as we see more than before. That's the fine precision medicine. It's up to us to take this uncertainty and make it into research and really to continue to investigate. So in other words, just follow the science. So with that, I would say thank you very much. And I took a little bit more time, and I hope to open it for discussion.
Thank you very much, Dr. Savir. It was an excellent talk with a very comprehensive overview of imaging and therapies that are available for PSM, for prostate cancer. And I'll open the podium for the audience. I do not see any questions in the chat box. I'll wait a few minutes before I ask my question.
Hello.
Hi.
Hello.
Hi.
Hi, we can hear you. Go ahead.
Hello.
Yes, we can.
Hi, we can hear you.
This is Ramanamurthy. Hello.
Yeah, go ahead, Ramana.
Actually, sir, sir, I have a doubt. That is, what is the role of gallium PSMA 11 instead of F18 PSMA, PSMA 11 and DCFIL? Is there any role? Suppose if you are any say prostate case, suppose which one you want to choose? Is it gallium PSMA 11 or F18 PSMA?
So I couldn't really understand. Someone can repeat the question. The question, sorry.
He's asking whether when you have gallium label PSMA 11 versus F18 label PSMA 11 versus F18 label PYL, which one?
Yes, yeah. You know, it's interesting because I said, am I going to speak about it or not? I can answer that because usually we're using one, but let me tell you what's going to happen. Now I learned that to my institution, I can actually get a 730 and 8 spots through Cardinal, which is going to sell me the gallium PSMA. I don't like gallium images to begin with. I'll be honest with you. It doesn't sit very well on my digital PET CT. It just creates a lot of issues. So, but I'm willing to give it a chance because again, tomatoes. So I am probably going to know that answer in the next year or so, but there is no really data to know one against the other. I think on a Petri dish, at the end of the day, you're looking at affinity. There is what's going to come very soon, recombinant PSMA. 7.3 that has a very strong affinity to the ligand, to the PSMA. So I think it's about the affinity. I don't know if it's studied, and if it was, I apologize. If the affinity of 11 compared to the DPYL is actually checked one-on-one, and I think that would be the key. Majority of the studies showing essentially almost the same data, minus the primary prostate, but I think it's very depends on the population, showing the same data, at least on the recurrent disease. So I want to believe that the answer is no. There is no differences, but I don't think I can answer it. I don't have that experience, and I don't see it publishing as much.
One more question, ma'am.
Hi, Bital.
One more question. I want to ask one more question, ma'am.
Go ahead.
Is it before going to start lutetium PSMA therapy, 617 therapy? Are you doing any salivary gland imaging? Because while doing lutetium PSMA therapy, salivary gland is one of the physiologic tracer uptake. So if you are getting large amount of activity while therapy, like 150 millicurie to 200 millicurie, so salivary gland will be, I mean, their patient will suffer lutetium.
Absolutely.
So is there any salivary gland imaging you doing while before going to therapy?
So I'll tell you, I don't do any salivary gland images in the United States. As you know, everything you do, you have to bill. I can't bill for that, so I can't do it. But that being said, if you go to the History of Iodine 131, it's exactly the same concept. There is a very high rate. So when I started with my early patients, it was from the compassionate therapy that before FDA approval, the guidelines say you don't have to use the ice pack. And then when patients came back, I said, what are you doing? Are you like, how do you feel? Do you feel? And then majority of them had dry mouth, which is unacceptable. So now I'm starting to use that. On the iodine world, we know today compared to 2005, that says that if you stimulate that with lemon, you can hurt someone. We do know that continuous stimulation of the salivary glands actually mitigates those side effects. I'm not sure I can apply that without data. So one of the things that I'm planning to do in my free time, of course, which I don't have at this point, but that's on our planning to do, is to really examine the kinetics of it, if possible. And that's easy to do. It's just for technique. And really to see if there is any protocol, including the same one I'm applying for my iodine theranostic, would work for this population. And again, you can't really do 24 hours images because you have to do intervals on the iodine, at least between 30 minutes to 60 minutes stimulation. And I cannot have them for 24 hours in my lab. So that being said, it will be very hard to prove, but we have to do something about it. It is a real deal, and it's a very, very strong side effect.
Ma'am, one more question, ma'am.
Hold on, let somebody else ask, please. You can post your questions and we'll answer by email.
Okay, sir. Okay, sir.
We have question from Naranji in the chat box. The question is, do you think prostate imaging with total body PET is going to change the horizon? And do you think that the treatment should be concentrated to specialized centers, or can anybody do it?
Okay, this is a great question. First of all, I think the beauty of the whole body scan is really the ability to, I'm sorry, I'm not sure. Did I do something? Oops, did I do something? Do you guys hear me, right?
Yeah, we can hear you.
Okay, good. Something. So basically, one of the things that I do see is that the best, if I can look at the best thing about the whole body is really to be able to look at the dynamic and the flow, because no matter what tracer you're using, you see flow very fast. And we don't take that into our advantage, looking at the kinetic of the uptake. But when we're looking at PSMA images, I don't have the whole body PET, first of all, but I read a lot of studies, and I think it's more for the clinic. If you have a very, very busy clinic and you want to do like 30, 40 PETs a day on this one, you can do that in a couple of minutes by just doing one bed position, do the amount of time you need according to your reconstruction, and let the patient go. And then you can actually have a huge center should you have that referral. But when we're looking at a PSMA images, when it's a key and a lock, I'm not sure it's important. When I'm looking at metabolic tracers, such as proliferation, such fluciclovine, choline, maybe that can give us something. So I don't think it's going to change the horizon when it comes to PSMA specifically. And then the other question, so yeah, you know what, another thing, in the United States, and we saw that in the cardiology world, once the nuclear medicine scientists doing all the images and it builds very well, you know, if you're a 340B pharmacy, meaning that you can actually buy your products in a lower amount of money and reimburse more, you can make millions of dollars to the hospital at the end of the day. So that being said, you end up having a lot of fight with people that want to have a piece of that fruit, and it's a very nice fruit, and it usually comes from radiation oncology. And let me say, this is unpreventable. We are not as broad as them, and prostate cancer is a very broad disease, and we unfortunately did not take care of our training. So not a lot of people that are actually doing residency in the United States are interested of doing theranostic activities, and they're drawn into the diagnostic world. So, you know, I see my friends here. We're very, very, I call it the unique animals, because we still do them and we like it. And you know, it's one of my Chicago friends group. We have our own chat that we talk about those things. And at the end of the day, I can tell you it's a big concern. So instead of fighting it, I'm trying to build something that will be in conjugation, but the money will still come into the world of medical imaging as long as nuclear medicine sits within the world of radiology. If one day the world of nuclear medicine will sit within radiation oncology, it's a different deal. Another tendency I see that oncology are trying to also bite that area, and I have to tell you the truth is that they don't have the training in radiation biology. They know about toxicity, they know about chemotherapy, but the way to handle radiation therapy toxicities is different. Like, you cannot stimulate the bone marrow. You can actually kill the bone marrow if you're stimulating it while there is radiation within the body. So it is very important that the oncologists will let the people that understand in radiation biology, whether it's nuclear medicine or other specialties, to really do those treatments. Radiation oncology sometimes may dilute themselves too thin with everything they do. So if they choose to do nuclear medicine therapies, they need to really join the nuclear medicine division, and they need to be trained to do that and not to do everything together, because that's where our problem is going to start. So I don't know. I hope we can go more in time. I see we have more discussion, so it's up to you guys. I have time to go beyond the hour. It's Saturday for me.
That was wonderful, Dr. Sival. I mean, that was wonderful synopsis of prostate imaging and therapeutics. And thank you. You answered my question. Thank you.
Oh, thanks. My pleasure. What other questions? I'm okay going behind time if someone want to stick around.
Partha Sinha has question, from Buffalo, New York. They say that currently, how soon can you get the dose after ordering? We have about 5 weeks wait here at Buffalo.
Yes. So it's not just Buffalo Grove. It's not just Buffalo Grove. My God, KJ, did you see what I just said? This is a place in Illinois. I told you, it's kind of my heart. So, well, now Novartis have a website, and I don't know if you guys had that experience. I decided to learn that and not just do it with administration. I needed to know what I'm facing. So when you go in, you order, everything is, first of all, today, if you want to order, you don't have anything to order, I think, into late October. I ordered for my patients. I knew they're waiting on the list. I already ordered all of them for 6 doses. So that being said, at each institution going to hold 6 spots for 1 patient compared to Sofigo that you're ordering it 2 weeks before. So the answer is yes. They also do not even opening new sites. I had to fight with them that I'm not a new site because I'm delivering it to the companion therapy. So they opened me, but I can tell you that they're not going to open new sites because there is more demand than the products. But the horizon is right around the corner. It's not like, I believe that in a year from today, we're going to have at least 2 more competitors that are coming and delivering those therapies. So Novartis, the same as the COVID vaccine, we're not going to have only 1. There is one question I didn't answer about the straight nukes or MR or both initial biopsy. I unfortunately still don't see whether I was at Loyola or here in Tucson in University of Arizona Benner. I don't see yet that the referring physician changed their set of mind of integrating those biological studies into their practice constantly. I am constantly doing outreach. I'm constantly calling, but I can control so much. I can control what happened in my institution. I'm the co-chair of the outreach committee, so we do a lot of work to explain those guidelines, and maybe we will be able to incorporate biopsy with a combination of both, and then you have to have the softwares for that, because not every institution has a PET MR. Go ahead.
Yeah. Next question is from Shyam Shri Sinha. Hello, this is Shyam Shri. Thanks for the enlightening talk. I'm a little confused about the lymph node sensitivity and specificity reported in the trials that you described. Were they all scanned positive nodes biopsied for the study to compare the two scanned PSMA versus fluciclovine?
Yes. So as I said before, everything that I showed, beside one slide of a detection rate by PSMA, that by PSA level, everything that I showed is based on histological confirmation, which is what I usually use. So the answer is, on the recurrence setting, you don't open the person and you start removing everything and do lymph node dissection. You just don't do it. You only go and target what you see. So then it's a bias, right? Because you go in to a specific area, you take it out, and now under the microscope, you can say where you're right or wrong. But if you have someone with negative images, you're not going to start getting it. But if you see negative images on a patient that has positive PSA and had his prostatectomy, for example, in the past, you know that your image didn't show it. So you basically call it false negative. But for the biopsies are positive, yes. For the world of primary disease, it's very important to understand it's a different method, because someone goes to surgery for radical prostatectomy and lymph node dissection, meaning that they remove the prostate, they go area by area by area, and they remove every lymph node they can actually see, which means that at that point, the amount of lymph node that they removed is much more than the one you saw on the scan. So of course, the sensitivity now going to go down. It's the same concept. If you go back to the history of mammography, when we thought that mammography will be the answer for everything, and then we have the breast dance, and then we realized that we only went after what we saw. We have better methods on this population, and now we realize that the mammography sensitivity for certain population is actually the 20%. And that's why there is the argument of the task force whether or not to do mammography between the age of 40 to 50. So again, taking all of that together, that's where the differences in sensitivity, specificity. And again, for those studies, they're standing by themselves usually. You don't have many times head-to-head. And the head-to-head studies that I did show that looked, I didn't even go over the sensitivity, specificity, because they're all detection rates. Those absolutely didn't have much of confirmations beside imaging. So as I said, we need more studies to compare that to. Hi, Dr. Halker, I just now seeing you. I am delighted to have you here. He's one of my father figures and mentors. So I'm happy to see you here.
Bital, I have a question. So after the FDA approval, we all saw in United States a lot of enthusiasm and a lot of referrals, right, coming to the Theranostics for this PSMA therapy. But in the real world, when we look at the real world where we practice, since there have been a lot of patients who have been waiting for this therapy, we are seeing a lot of patients who do not fulfill that FDA approval criteria. So how do you deal with oligometastatic disease, patients who do not want to start docetaxel or chemotherapy, and your oncologist colleagues want to have this treatment, which is the correct, right decision, but how do you deal with this?
So I have one patient that I'm facing with right now. There are a couple of issues here. Yeah, because we don't really know if PSMA is going to work as good as first line. We just don't have that, right? So the studies that I show going to look at that. And we have to follow the science. So if patient doesn't want to go on chemotherapy, doesn't mean it doesn't need to go on chemotherapy. So it's not the correct way to go. And I have to tell you from my personal experience and what I know from literature, knowing that the Cabozit XL has the same overall survival as the PSMA. If that will be proven for the first line compared to Doxit XL or with Cabozit XL together, that would be much easier to come and say, okay, go ahead and do it. It is a very heavy weapon that we need to use. And once we give it to someone, it may take forever before we will get into the point in the United States that we can give it as another cycle. You know, chemotherapy today, if now just to bridge until I had that approved in my institution, they just took from the drawer. So you know what? I'll give you 2 more of the Doxit XL. I'll give you 2 more of the Cabozit XL. I will bridge you with something. I cannot bridge anybody here with iodine therapy or anybody with Xofigo. I can't bridge them. It doesn't work like this. So we are yet to be there, and I hope that the Society of Nuclear Medicine will eventually make that happen. But for your specific question, we need to follow the science. But and they're gonna have to start chemotherapy. But what about those patients that are contraindicated for chemotherapy? That's the question that we need to ask. Are they going to receive it? And yes, patients that are, for some reason, either a prior renal failure that now their kidneys are fine and are eligible to receive that therapy, can they still be receiving in the United States the PSMA therapy? Yes, in oncology, and this is where you have to include your oncology team. The oncology team authorization approvals actually say that every patient and that's based on reimbursement, that every patient that has contraindication to receive the chemotherapy that approved by his physician immediately skip to the next line, and we are in the next line. So the answer is yes. I have 2 patients that cannot receive chemotherapy for various reasons, and they're going to be approved to receive the Pluvicto. I didn't see any denies.
Thank you very much. I guess, do we have more questions?
So is dynamic PET-CT useful in the detecting lesions? So this is very interesting because, you know, I had actually the discussion about it with David Schuster, because you guys have you have the PET-MR, and in order to actually do some images on the MR, you can actually operate the PET, and this is where you see very, very interesting dynamic just from it. To tell you if there is a role for that, I guess we'll all have to wait for David Schuster's, unless Dr. Halkar, you have the experience, you can speak about that yourself. But I don't know if there is any specific useful, again, for PSMA, it is a receptor base. For fluciclovine, it might actually be that, you know, one of the problems with fluciclovine is that when you do the early images on the delay, you don't have that. And then a lot of the sensitivity when you do 4 minutes, we know from intra analysis of our data, we didn't publish it yet. The sensitivity is 80, 90, but the specificity is around 67, which is actually flipped from the original data that the sensitivity was around 60 and the specificity was 97. And why is that? It's because when you do 4 minutes images compared to double time that we did 3 times images back in the days, up to 60 minutes, 3 bed position, three time points. I was up to 14 minutes and then up to 30 something minutes and then up to 1 hour. This is where you can see washout. And this is where your specificity is increasing significantly, because the majority of the benign lesions that are having reactive processes will actually wash out. And I think that's where the dynamic can help. But again, and for those that actually it's like going on the same position again and again and again and again. And this is how you get kinetics. I can tell you for brain lesion, it's probably going to be awesome, but we're investigating it soon.
Bital, question from Dr. Josna Rao. How soon after hormone therapy does rebound occur on PSMA scans?
So we don't know. If I would have that answer, trust me, I would be much wiser today. We don't know. And we try not to use that on hormonal therapy. And I bet that the people from UCLA that have a wide experience on PSMA probably came across that question. Tom Hope is actually the one, if I remember correctly, that looked at that, and he's one of the biggest Theranostic investigators today in the country, and he actually the one that suggested that, and it's actually been shown by additional, and it's cited on my paper, additional investigators, and we really don't know exactly the time that it plays between the long term and the short term, and we really need to investigate that, because do we really, we don't recommend to stop hormonal therapy, but we do recommend to get the staging or restaging images before you start hormonal therapy.
Thank you very much, Bital, for taking time out. And I'm reading what Chitra just said, and these are, I'll echo the same words. During the long weekend and giving a great talk, we are all extremely grateful.